Hi, everyone, and welcome to the program Ethical Dilemmas in NP Education. My name is Dr. Vanessa Pomarico and I'm so delighted to be joined by my friend and colleague, Dr. Brett Snodgrass. Brett, would you mind introducing yourself to our audience, please?
Thank you, Vanessa. Yes, I am Dr. Brett Snodgrass. I will just briefly say I'm a family nurse practitioner by trade. I am currently the Director of Operations for a large palliative program in Memphis, Tennessee, and I am a Fitzgerald Health faculty. So I'm thrilled to be with you tonight, Vanessa.
Thank you. And I'm also an FNP. I work in primary care. I am the lead clinician for diversity, equity, inclusion, and belonging for Northeast Medical Group in Connecticut, Rhode Island, and Massachusetts. And I'm also faculty for Fitzgerald Health Education Associates. So Brett and I are really excited to bring these ethical dilemmas. This is something that is we are both very, very passionate about. We're going to ask you to hold your questions. You can put them into the Q&A and we will address all of them at the end of the session. But we have a few things that we've talked about that we thought was really important to bring up to all of you today. So one of the things that we had talked an awful lot about, and Brett being the expert in end of life, is talking about end of life decisions and the conflicting opinions among family members. So would you like to just address that a little bit, Brett?
Yeah, I mean it's we know what it looks like, right? Perfect world is everybody is on the same page for end of life decisions. Um, the different decision makers, in the perfect world, there's a POA of healthcare, there's a living will in place, and everybody kind of knows their place and what mom or dad or whomever wants and desires when they can no longer make their decisions. I think where ethics plays a role is when we begin to talk about what about those differing opinions? Who gets to make that final say when it isn't perfectly cut and dried, when it isn't a power of attorney of healthcare? So I guess a couple of concepts just to briefly run through, and you jump in at any time, Vanessa. The thing to know about power of attorney or durable power of attorney is that's not the same thing as a power of attorney of healthcare. So just because you've gone to the attorney, you've gotten kind of your affairs in order, unless there's a stipulation within the verbiage, a power of attorney for finance is not the same thing. So you can bring the paperwork in and say, I'm power of attorney, but power of attorney of healthcare is different. And again, it can include it in a durable power of attorney, but it's not always there. So you have to be really careful if you're going to an attorney and kind of getting your affairs in order. Because sometimes our attorney friends don't know the appropriate paperwork. So that's one. There needs to be a power of attorney of healthcare. And then kind of talking about who gets to make those decisions. Every state's different. So I always say, know your state rules and regulations. In our state, it's not always just the oldest child, or it's not always, it's more who has been more involved in the care of the patient and things along that line. Two things I'd bring up that me and Vanessa talked about was things to know is, let's just say you have been separated from your spouse for 20 years. Never got an official divorce, not together, hadn't seen him, who knows where he is. That type of situation. Keep in mind, if anything catastrophic ever happens for you, he actually is still your decision. He, she, whomever, they're still your decision maker. If you are legally married, if you've never dissolved that legally, they're still your decision maker. And that is kind of an aha moment for a lot of people where they're like, what? I'd never want him to make my decisions. Flip that around to say, if you are living with somebody you've never legally gotten married, and we talk about common law. Common law is not observed in a lot of states. Tennessee,
Right.
for one. So just because you've been together for 30 years and you've just not officially gotten married, that technically is not legally your decision maker unless you've made your decisions known with that power of attorney of healthcare or an advanced care plan or something along the lines. I always bring that up first because that's usually the thing where people clutch their pearls and say, what? But it's true. So it's really important that our patients have things written down, and have things appropriately put into place so that you do have who you want to be your decision maker to be legalized and available if that need ever arises. We hope it never does, but it can.
So on the same vein, you talked about common law marriages, which are recognized that they're actually called registered domestic partnerships here in Connecticut.
Yep.
But how about our same-sex couples? So there was a time I remember when I was working in the hospital, there was a same-sex couple, and as you had mentioned, even though the woman was divorced and she was with now her female partner, the laws in Connecticut at that time precluded the partner from making any kind of healthcare decisions. And this was an oncology patient. And the ex-husband had to be found in order for us to follow through with, at that time, her living will. So when it comes to same-sex partnerships, what kind of ethical suggestions do you have for people that are starting to deal with this? Any clinicians out there?
I would say simple enough. Who do you want to be your decision maker? So, in all reality, if you are legally married, that should be the decision maker. Can I promise in every state that would be observed? I can't because we don't have, and as far as I know, and Vanessa, you know better than I do, all states don't recognize the
Mhm.
marriage. My recommendation then is to take that next step and just make that person your power of attorney of healthcare, just so that there is no question. I know I've worked with a number of same-sex couples, and that is absolutely who we look to make their loved ones' decisions. But I do know that different states differ, and I always say take that next step. If there's ever questions, take aside same-sex marriage. Husband and wife would not hurt for you to go on and have a power of attorney of healthcare, because you're just giving that extra layer to make certain who you want to make your decisions is identified appropriately.
Exactly. And going the next step to find out what are your state regulations.
Yeah.
So
Yeah.
just interestingly enough, just FYI to everybody out there that the Joint Commission actually has built this into their standards of care, that same-sex couples are offered the same courtesies and the same rights as any other patient. So hopefully that will give you a little bit of food for thought. But I would highly recommend that you look into what your state, the laws in your respective states are.
Always. Always.
Great. So the next thing I want to talk about, this is something really close to my heart because I've had a number of times that this has happened to me, about nurse practitioners who prescribe either for themselves, their spouses, or their family, or perhaps maybe treating family members who may or may not be patients in their practice. What are your thoughts about that? And then I'll share my little story that I had.
Yeah, and what I was going to say is I think it's important that whoever's attending here know. I don't think there's always cut and dried yes and no. Right? So you can see things a little bit differently. So let's see what you and I would say about that. The very simple thing I would say is if it is controlled substances, you should not be prescribing unless there is simply no other way, right? And so I was thinking about this today. Let's just say we live in some remote Alaskan village and you are with your husband and he breaks his leg and you're the only provider, right? Like, what if I always think I'm the devil's advocate always. So, like, what if, like, okay, in my opinion, in that situation, and only in that, like, very small subset that usually we wouldn't be in, then I think we might have to throw caution to the wind. And so then my recommendation would be you better have a chart on them. You better have done a physical examination. You better have verbiage in that chart to say this. I attempted to have another provider. I attempted ways to get that paid, and then we're going to prescribe very small amounts. And, I'm just thinking of any way we would get around it. I would tell you 9 times out of 10, don't do it, especially if you are anywhere where there are other providers. It would be frowned upon if as another hat I wear as a reviewer of charts for misprescribing. So 9 times out of 10, it is not appropriate. Now let's talk about sprain strains, an NSAID, maybe a Z-Pack, which we don't like, maybe, an antibiotic, very appropriate prescribing for whatever the reason is. Again, I don't think it's good practice. I just don't think it is. And let's talk. So we're talking about families, and then we're talking about friends. You are on a slippery slope with friends because you do it once, you're tied in. They will
Hmm.
be your next phone call anytime anything happens. It's just not good care for them, and it is not a good thing for you to begin to take on. And then family, same situation. They don't see providers, they don't talk to them. You're doing things kind of, and I get how that happens, but it's just not good practice for your families either. So I always say rule on the side of caution. I don't recommend calling in, prescribing anything for family members or friends. I mean, I'll let's talk friends. I had a practice. I had my own practice for a long period of time with another provider, and yes, I saw friends, but they came to my office, they paid the copay. I had a chart on them. I was very comfortable. So I thought that was okay, but it was never this under the table, hey, call me in augmentin because got a runny nose. I think that's poor practice, but I think you take a next step if you've got a controlled substance. Be careful.
I completely agree. And so, as somebody who taught pharmacology for many years on the graduate level, that was always my pharmacology 101, introduction to pharm. And I would always say, just because you have a license doesn't mean that you're able to prescribe for friends and family or people who are not your patients, because ethically it can become a huge dilemma. And if you ever get audited, you have, let's say, a pharmacist who recognizes the last name and they call on it. And so I will tell you that that did happen to me. My mother was a patient of my practice. Her PCP and I have practiced together for 25 years. I happened to be on call. I happened to be seeing my mom that weekend, and I needed to call something in. But I did the right thing, exactly as you said. I made it an encounter. I made sure that it was documented, but the pharmacist did call and say, "Are you related?" Well, with a name like Pomarico, you kind of think we're going to be related. And I explained that I did work for the practice, everything was documented, and I made sure that my practice manager and the supervisors above them knew that this was happening so that it didn't ever come back. But I will tell you, there is a story that I do want to share. So, I had a patient of mine who was a nurse practitioner who actually used to be a former student of mine. So, they did sit through my pharmacology class as well as all the subsequent classes. And that was something I drove home to them about not prescribing. Well, apparently they might have zoned out that night, but whatever it was, I happened to be doing a pre op on their significant other. And anesthesia was doing med reconciliation and called risk management to say that as they were doing a med reconciliation, they looked and they found that the spouse had been ordering Xanax and Ambien. And when the patient, you were talking about sprains and fractures and that kind of thing, there was a short course of an opioid for, a broken femur or whatever the fracture was. And when risk management got involved, they called me and I said, I had no avowed knowledge of this and I don't want anything to do with this. So I documented it. I was not going to take responsibility. And I actually called the patient and said that this was going to put my license in jeopardy. But also, too, the nurse practitioner was going to have an issue because now risk management was involved and they also worked for the health system. And the NP ended up losing their job, and the wife was actually dismissed from our practice because even though I had said during the med reconciliation for your pre-op by your anesthesiologist, they found this, you really need to stop this practice. They didn't care and they continued the practice. Well, of course, once your chart has been flagged, you know that they're going to continue to look at it. And sure enough, the NP ended up losing their job. And that's not something that you want to follow you with other positions. And we all worked so hard for our licenses. I can't imagine putting my license in jeopardy for something like that. Now, in the ethical piece of the pharmacology class that I taught, one of the things that we talked about, like you were saying, you're in Alaska or some remote area. Somebody said very recently on a social media account that I moderate. And they said, well, what's wrong with calling in a Z-Pack, which I know neither one of us like, or a course of Augmentin. My kid's got an earache. It's a Saturday night. And I'm not going to get anybody to see my kid until Monday. So what's the harm in doing it? But again, if you haven't made an attempt, and let's face it, we all know that pediatrics, they're on call 24/7. They have office hours on the weekends. So you can justify your behavior any way you want, but in a court, if you ever get pulled before if your particular state is, if it's the Board of Nursing and or the Board of Medicine, if they do it conjointly, you have to really explain as to why you thought it was a good idea to call something in for a family member. So you just never know when you're going to be audited, and especially in this day and age where we have electronic health records, where it's so easy to pull an audit just by typing in a few words and they can pull it out. I just wouldn't take the chance.
Yeah, and you did all the right things with your mom. Like that's perfect. That's exactly what you would do. So I think that's perfect because you said, here's what you should do. Like if it happens and trying all the things, you did all the right things. So I think you do your very best. I always say that, you know, it's hindsight's 2020. Like we would do things differently if we knew it was going to happen. So you do the very best you can in the situation you're in. But yeah, I agree with you when it comes to controlled substance, opioids, all of those things. I would shy away from all of that. And then again, it's just a slippery slope. You do it one time, and oftentimes you're going to be tasked to do it again. So it's not often a one and done, and then you get into the cycle. I sat on I worked with one of the boards of nursing, a state board of nursing, and it was with a nurse practitioner that was doing just that, writing
Mhm.
prescriptions for a loved one multiple times, larger amounts each time. And you could tell she was very young. She probably got in over her head and then could not get out. So like you said, it's your license. We've worked too hard to get them. So by all means, protect them at all cost.
And every time I read about a nurse practitioner losing their license or going under a consent order, it just gives our physician colleagues all the more ammunition to say this is why nurse practitioners shouldn't exist. So again, we've just worked really hard for our licenses. Just do the right thing ethically. You can never go wrong. Extenuating circumstances aside, you can never go wrong.
No, I totally agree.
All right, so let's move on. This is another one of my, probably one of my biggest pet peeves, and I've actually worked with the hiring department at our local hospitals. But how do you feel about people who become family nurse practitioners or an adult nurse practitioner, primary care education, and then they go to work in a CCU or some type of ICU after graduation? What are your thoughts about that?
Yeah. Well, okay, so the blanket, okay, so I've seen a lot of hospitals that have put that into place. No family nurse practitioners, no adult gero primary care in the hospital, period. I want to be really careful to say I'm a family nurse practitioner. I practice in a hospital inpatient. I'm not a hospitalist. I am not working in ICU. What I'm doing is working in palliative medicine and hospice, and I have all the right in the world, and I'm not outside my scope of practice, right? But I think we have to be really careful if we are taking these jobs that really are stretching our scope of practice. Now, I think we could probably debate, is a hospitalist outside of the scope of practice? I don't know. I think we could all agree pulmonary critical care or intensivist in ICUs. I think for a family nurse practitioner, adult gero primary care, I always try to remember what those are, or the different names. But I mean, I think you're outside of your scope of practice. Now the debate is, if you practice with somebody, you learn from them, you do extra training, are you able to do it? I have seen nurse practitioners that are family nurse practitioner trained, probably that this are some of the best in
Mhm.
the ICU. But you know what? I actually had one very dear friend who actually I precepted, and he was an amazing nurse practitioner. So his care, I do not question, but I did question when he took a job in a burn unit as
Wow.
kind of, yeah, I know. And I was like, you need to be very careful in what you're doing. Could he do it? I don't doubt he could do it. My concern was if there was ever a problem and your license are going to follow you, and they would say, what training do you have? Now he's worked many years in ICU. He has all of that training, but not as an advanced practice provider.
Right.
And not that, and of course he has on the job training. Like he could do the job, but he did not have the degree to go along with it. I think you've got to be really careful. I mean, what do you think? Let's turn the tides. What do you think? You're in a big hospital system too.
So
Hospitalists,
interesting.
this kind of, what do you think?
Our hospital system for many years was hiring FMPs who were critical care nurses in their respective, ICUs. And when we got a new vice president, she said, we are not going to do this because in a court of law, they will ask, just as you said, where in your NP education did it train you to intubate somebody? You could have been the best critical care nurse for 25 years. Most of them, like you said, are they capable of doing the job? Sure. But
Yeah.
where in their education did they learn the theory behind the practice? And they didn't, because again, as FNPs, AGNPs, ANPs, we are educated to be primary care providers, not acute care providers. So your acute care training as a nurse and experience as a nurse comes into play. But again, different level. We're talking about RN experience versus nurse practitioner experience. And that's where you're going to run into trouble. So it's interesting that your health system really took the lead on not hiring FNPs for the critical care unit. We do have some FNPs that are in our hospital system very similar to what you have. What you're doing, you're not outside of your scope of practice. But we still have some people that are FNPs, and we don't have so many AGNPs, but ANPs who were hired into the critical care arenas, and they're still working there. And I always
For our
say,
younger audience, A&P, you mean adult nurse
adult
practitioner.
nurse practitioner,
Adult, yeah,
yes,
yeah, yeah,
yes.
yeah.
But that was before people had to be dual certified. There's still
Exactly.
some people out there. I think it was as recently as 10 years ago that somebody could go to school to be an adult nurse practitioner without taking the GERO piece. So thank
Well,
you.
the funny piece of that was when the hospital system was trying to work on magnet certification, and
Exactly.
that's where that came from. And the funny thing was, we were all called in that were FNPs, and they were like, great news. Do you want to go back and be an acute care nurse practitioner? They made it sound like it was a weekend
Right.
camp program. And I was like, not in a million years. I mean, I've got friends that are dual certified and they are amazing. But I was like, they made it sound like literally like in a weekend, you too can be an acute care nurse practitioner. And I was like, nope, not doing that.
Yeah.
So again, it tells you what administration knows about what we do in our practice. So, nonetheless, that's not ever held water. Like we've still practiced, but again, we want to practice within our scope.
Exactly. And I think you mentioned it succinctly that it's really for those magnet hospitals that now it's written into the standards for magnet status. And so they look at that to make sure that, and I was actually sat in on one of the magnet evaluations, and that came into play at the table. And I remember thinking they had asked me, how do you feel about that? And I was I know I didn't make a lot of friends at the table that day, but I was very to the point and said, I don't agree with it because if it was me or my loved one, I don't care how good of a nurse you are,
Right.
if you don't have that practice, that theoretical foundation behind the practice, I don't want you working on my loved one or working on me because you can mimic it, you
Hmm.
can be a parrot, but it doesn't
Hmm.
mean you have that background, that appropriate background to be doing so.
And let's flip it around. So, a lot of times, what you'll see is they want a family nurse practitioner because you can take care of younger children, right?
Exactly.
Acute care nurse practitioners are not trained for that either. So, I always challenge my ACNPs, be careful going and working in a primary care office. You truly
Right.
haven't been trained in that side of it. Can you do it? Are you a parrot? Can you? Yeah, absolutely. But be really careful, especially if you're taking care of children that is outside of their scope of practice. Or an adult gero primary care nurse practitioners. Be really careful.
Yeah, exactly. And, to that point, I actually know somebody who went to school to be an oncology nurse practitioner. and was specialized at I don't even know if those programs even exist, but it was one of the schools around here actually had an oncology nurse practitioner program, graduated as an oncology nurse practitioner, is now working in primary care.
Mhm.
Okay, again, you can learn it, but are you really doing the right thing? So you really need to think about, and I always say to people, think about why you want to become a nurse practitioner. And if an FNP is just easier, cheaper, an easier program to be accepted to, but you know that your end goal is to work in the ICU. I can't even say the ED because there's a lot of EDs that will still hire
Yeah.
an AGNP or an FNP, but in the ICUs themselves. And I always say, ask yourself if that's your end goal, then get the appropriate education behind you, even if it means delaying your education by a little bit. Because again, in a court of law, they're going to ask you, where in your training allowed you to do this, especially if, and we know that in the ICU, things can go wrong very quickly.
And another, again, you can tell the subject gets bigger and bigger, psych mental health.
Right.
If you're a psych mental health NP, you're not a family nurse practitioner. You've got to practice with, now, usually, not usually, oftentimes, our NPs go back. So they get a certification in psych mental health. Well, then you're dual certified. But be careful if you are a psych mental health nurse practitioner, again, same situation. You need to practice within that scope. And that usually doesn't include being a family nurse practitioner. It doesn't include that kind of care. You haven't been trained to do those things. So,
So, and just to kind of segue from that, we also have to think about those people who were AGNPs or ANPs that are now working in psych practices doing medication management. Now, it is perfectly within our scope of practice to treat anxiety and depression, but some of the more serious psychiatric illnesses is not something that we're trained to do. And I'm finding in really across the country, people that have not gone back to get their psych NP, that they may be an ANP from years ago or an AGNP or even an FNP, and they are doing medication management for some of these really big psych practices. And that's a little bit dicey. That's where you're really starting to walk a very fine line on what is really within your scope of practice. So again, for those of you who are hearing this, just think about where you want to be and how you can best get there in the safest way possible without compromising your license.
yeah, that's perfect.
Okay. All right. So you know that that gender is one of my specialties and another thing that I hold very dear to my heart. And I do an awful lot of training on taking care of the gender diverse patient. So, how do you feel about confidentiality regarding a patient's gender or their gender identity? So, for example, you're rounding in the hospital and you happen to hear two staff members talking about the patient behind curtain four. Did you get a look at that guy? They're a tranny. Tranny is a very derogatory term, but these are the things that I hear at the hospital. How do you feel about the confidentiality piece regarding a patient's gender?
I'm going to tell you, I don't feel any differently than anything else that they would be talking about. Number one, having a derogatory conversation about anyone is wrong, right? I think we'd all agree like that's unethical. I think we have to be even more careful in this day and age. Um, it- we take care of transgender patients all the time. And I find it very interesting because you will hear people that refer to the patient as what they were prior to their the change and things like that. And to me, I think we meet patients where they are, so it's not for me to judge what depending on how you feel or not feel about those things. So whenever I hear anything derogatory about anybody, whether it's transgender, whether it's racial, whether it's gender, whether it's whatever, I have such a problem with that, and a red flag goes up, and we know it's not appropriate. So again, I know that's close to your heart. What are your thoughts? What conversations do you have? And I don't want to also chalk it up and say, well, they're the same as everyone else. No, I think we have to treat things differently because we're in a new age. So let me turn it back to you and say, you tell us, Vanessa, what's right? What should be how should we handle it?
So, again, you have the right attitude toward it that we have to look at it We can't just be heteronormative and just say, I love everybody and I treat everybody the same. We have to think about different religious preferences, different ethical preferences. And one of the reasons why I do so much training at the hospital is because we do see and we get complaints from patients that they have overheard staff members talking about them. So I know that NP education and undergrad education is largely devoid of any information regarding taking care of the gender diverse patient. And really now with all of our DEI initiatives being removed from education, the content is non-existent. So for those of you who are listening today, and you haven't had any training on that, please get some training on it. If your individual institutions don't offer it, there are so many online programs. I know that Fitzgerald by Calibri has many of them. Some of them I have recorded, some of them other people have recorded. If you can't find it, please reach out to me and I will make sure I can find some resources for you. AAMP also has some, but there are continuing ed um, offerings that you can get the appropriate training on them. Now, will that make you an expert? No, but it certainly will make you a little bit more comfortable in talking to the patient. Now, that being said, you happen to walk by, you're going in to see a patient, and you hear two of the staff members saying something derogatory about the patient in room 3. Now, I recognize that not everybody is comfortable with confrontation. If you are not comfortable confronting the person or the people and you're afraid that that may cause some consternation, then just simply go see your patient and then find the supervisor, whoever those people report to. Find the supervisor, bring them into a room where you can have a private conversation with them and just say, I happen to overhear two of the staff members saying something in a very derogatory manner about the patient in room 3, and it was inappropriate. Or, my patient overheard somebody talking about them. If you're not comfortable saying it, go to somebody that can and make sure it gets followed through on. Most institutions and most practices now have guidelines and standards so that there are ramifications if that person or that employee is not following them, where they get written up, and then if they get spoken to, and then if it happens again, then they lose their job. In this day and age, I hate to see anybody lose their job, but the amount of training that I've done, I've actually had people who have become very argumentative with me when I'm talking about how to speak to a patient and how not to speak to a patient. And really that think about it, because you never know if somebody in your life that you love is going to come home one day and say, Brett, I'm gay. Brett, I think I'm a woman. Brett, I don't know what I identify with. And you just never know. So don't be judgmental. Calm your patient down as much as they can. Many of the patients don't feel safe as it is, but to walk into an office and be misgendered or to hear them being spoken about in a derogatory manner can be very, very damaging and very, very activating in patients who have a lot of anxiety and some PTSD. So we have to recognize the ripple effect of what this little conversation can have on what can happen with the patient experience. If your particular institution doesn't have guidelines or disciplinary actions for this, then maybe you start a group and do a little bit of fact collecting and come up with some guidelines so that there can be disciplinary actions. People should not be allowed to have modern day bullying and abuse a patient that way. Our patients are at their most vulnerable when they're sick. When they come to us, especially if they're gender diverse and they don't necessarily identify as male or female, it takes an awful lot for them to walk in the door. So, have a little heart with them and have a little bit of patience, but also you need to be their advocate.
And how would you manage any other patient with PTSD and anxiety? Their road has not been easy, right?
Right.
Let's be honest. In 2025, that road to get to where they are, again, take out how you feel about it, but their road has not been easy to get there. So think about the patient you're going to deal with as you're caring for them. They're going to come with things like PTSD, anxiety, those things, and you're going to have to help them work through those things. Yeah.
And the majority of our gender diverse patients have PTSD. They have been mentally and physically and sexually abused. And to have, again, the fortitude to walk into the door with a new provider only, or even to go to the ED. So, and I will tell you, I happened to be at the ED one time with my friend who happens to be trans, and has no other family that was around at the time. So I took him to the hospital. And as I was standing there, now again, I do work for a large health system. It's not like people don't know what I do. I kind of have a red flag when I walk around. The girl with the hair is here. And as I was standing behind the curtain, I heard somebody say, "Did you get a look at the tranny behind curtain 4?" My head almost exploded. And so I said to my friend, "I'll be right back." And so I went out and I asked where the supervisor was. And I pulled the supervisor aside. I introduced and said who I was, because let's face it, I don't go to the ED a lot, and told the supervisor what had happened. I knew exactly where the voice was coming from because as I was having this conversation, I said, "Do you hear that voice? That's the voice that was saying something." And they immediately pulled that person aside and they were asked to leave for the rest of
Wow.
the shift. And then the next supervisor up from them actually had called me and said, "We want to arrange for you to come in and do some trainings." And so I had to do trainings over the course of a few weeks so that we got all of the different shifts. But had I not been there, that's what I always think about. Like my friend kept saying, "You don't have to stay here with me." And I kept thinking, you know what? You're trans. I really do need to be here. And I'm glad that I was there for him because I think it would have done a lot more damage. Like you said, PTSD, anxiety, they're already anxious enough. And to have something like that happen. So I'm glad that I was there because it opened up the door for further training. And it was just an education again on the supervisor's part to say, more people are identifying as something other than gender binary, male or female, masculine or feminine. And so you need to be prepared. And we don't get that in our nurse practitioner education or even in our undergraduate education. So we don't want any of you out there to then have to take care of a patient for the first time who identifies as gender diverse, and then you don't know what to call them. What do you say? What happens if you make a mistake? So get the education, get some training behind you. But ethically, you have a responsibility to make sure that the appropriate people know that a patient was being made fun of and was spoken about in a derogatory manner. And so, or morally and ethically, you have a responsibility to make sure that that doesn't happen again. Any thoughts on that?
And I'll just put in a plug and say, if you're at a national conference, she already said Fitzgerald Health, Vanessa does the best
Oh,
education. I've
thank you.
heard her time and time again, and I learn something every time. And again, this is education just to provide the best care that we can for our patients. So yeah, that's my
Thank you.
shameless, not even shameless. That's my plug for Dr. Pomarico.
Thank you. All right. So one of the other things I want to think about, because this is about NP, ethical dilemmas in NP education. So again, as somebody who worked, as a program director, an FNP director for many years, and being on faculty for FNP program, let's face it, there's not enough preceptors, and I'm sure many of you are shaking your head saying you're right. There's not enough. We don't have enough preceptors for our students. And so many times programs, although I will say not in my program, I was very happy to put them with the appropriate preceptors, but in some programs, they don't have a problem putting an FNP or an AGNP student with, say, a naturopath. Now, I don't know how things are where you are, Brett, but in Connecticut, a naturopath can't even well, they don't write prescriptions, but they can't even order labs. But a nurse practitioner student should not be working under a naturopath because our education is not in homeopathic medicine. If that's again something that you want to do, after that, then get the appropriate training or go to a naturopathic program. But putting a student as a rotation with a naturopath or as a collaborative provider. I mean, do you see any of that where you are?
When you talked about that, I don't see it specifically here. What we see more commonly is nurse practitioners paired with physician assistants. Now, is that wrong? No, I don't know that it is wrong, but we are trained differently, right?
Exactly.
Um, but then I also know that there's a lack of access, right, to nurse
Mhm.
practitioners. We could talk about that. I want to bring up something else ethical as we get through this topic because it just struck a chord with me. But no, I mean, that's not something I've seen here. But I think we'd all agree, like, that is not the same standard of care. That is not the same scope. Anything like that with that patient, with that provider. So no, I've not seen it. But we do know we have lack of access. Let me throw this out there. What about paying for preceptors? And I don't know that it's ethical, like, right? Like there's some, in my opinion, kind of better practices and not so great practices. What about paying for preceptors? Because that's what many of our students are having to do now.
Mhm. So I actually happened to be on one of the task force when they were talking about paying preceptors. Now, I've been in practice 27 years. I think that it is, and this is just a Vanessa-ism. This is doesn't speak for Brett or anybody else. This is not the Fitzgerald by Calibri opinion. This is a Vanessa opinion. I feel like when we precept, that is our way to give back to the profession. So I don't take the money. Now, they at one time they had all agreed, all of the schools agreed, if we're going to pay preceptors, we're all going to pay $200 a semester. We all agreed on it. That lasted one semester. The following semester, somebody said, "Oh, you really should go and precept for another school because they're paying $1,000." So I immediately got on the phone with the dean and said, what gives? Why are we paying $1,000 when we all agreed it was going to be 200? And the next thing you know, all of the programs in this teeny tiny little state of Connecticut were undercutting each other.
Wow.
So I don't feel, I feel it's something that we should do, giving it back to the profession. I do recognize it is exhausting. It is a lot of work to have a student. When you break down $200 over a semester, it's pennies.
Right.
And that's, kudos to you. If you want the money, take it. I personally, they made me take a check one time and I donated it into one of the nursing scholarships. That was just something that I felt strongly about doing. But I personally don't believe, I know that physicians get paid a lot of money to precept medical students, but I feel that, in nursing, we are always looking, we are lifelong learners, and our students keep us on our toes. How do you feel about it?
Well, I feel the exact same way. Again, I think I'm old school. And again, I've been a nurse practitioner for 18 years and a nurse for 28. So same idea. I've never taken money to precept. I never would even really consider that. I agree that $200 really doesn't cut it if we're really looking to make money. So what's $200? Um, but I feel the same way. I will say, in physicians' defense, a lot are not getting paid. So, we have a hospice and palliative fellowship. My physicians aren't getting, and myself, I even work with the fellowship. We're not getting paid. Now there's certain people are within the fellowship, but many are not. So, a lot, it is giving back to your to what we did. Like, somebody precepted us, somebody got us to
Right,
this point. I only want to give back. So I don't think it's ethical, like, oh, they took $200, so they're
exactly.
not. But it made me think. When you said that, I thought, what about paying? So I think that's
It's
an
also,
interesting
I
concept.
think it's also hard too because some schools they're rolling, like some schools they roll it in as part of the lab fees. I had another student that said that she actually had to write a check to her preceptor every semester, and I thought, students today, it's very different. I know when I went to school, of course, I went to a state school, very, very different. But people go to school now, and many of you out there are probably shaking your heads in agreement here. It's not cheap to get a college education. And then to have thousands of dollars tacked on to find a preceptor, I just think that ethically we can do better as a profession. I really do.
Yeah, absolutely.
So,
I think you're right.
so I have a kind of a hot topic button that I want to talk about tonight. Vaccinations are such a huge topic. How do you feel about nurse practitioners who do not believe in vaccination, and they then transfer that to their patients? So patients will come in and say, and let's face it, with electronic health records and pharmacies, everybody's getting all the reminders, you're due for this, you're due for this. And they come in and say, oh, I got a notification on, my patient portal that I'm due for a pneumonia vaccine or my shingles vaccine. And the nurse practitioner comes out and says, well, I don't believe in any of the vaccines. You really shouldn't do that because they have X, Y, and Z in there, whatever their excuses are. How do you feel? Do you feel that that's a good thing for a nurse practitioner to do, or how do you feel? Where's your stand on that?
I mean, what do you say? I have grown up in a vaccine environment. I don't know anything different. I wouldn't recommend that my children not be vaccinated. My grandchildren coming very soon in just a couple of days. I just am such an advocate. And I even was going around to make sure we were all updated in TDAP. And, have we gotten everything we needed? And we talked through it with the girls because both my girls are pregnant right now. But um, what I know is there are some really passionate providers about that. I think if you came to me, Vanessa, and I didn't believe in vaccinations, but you said, I need to get this, I want to get this, I want to get this, then I wouldn't stand in your way. Like I might say, I don't always recommend this, but let me make certain you can get access to that, right? Um, I don't know what to say. I'm lost at it because I can't fathom recommending not doing something that we know is sound information.
Right.
I get, and I always say this, you and I both teach nurse practitioner review courses, right? And I always say you can no longer quote the CDC. You can no longer quote the data out there because people do not trust data anymore. But I think you just continue to talk about what's always been recommended, what we got as children, what, oftentimes we gave our children. Um, I think we just provide the information that we have. Usually people vaccinate based on what a provider is saying. So our words are really, really important. So it's really hard for me to, I don't know, what do you say? Let me turn the tables on you. What do you say about all that?
So, I'm a big vaccinator. I grew up, my parents always, as soon as the vaccines came out, now I grew up and polio vaccines were already out. But I remember growing up, that my dad used to make a donation and he would get these little cards. And there was a woman, her name was Anne. I remember crazy things after all these years, and she was in an iron lung, and she used to paint or with a special dental appliance, and while she was laying in the iron lung, she would have this pencil and she did these beautiful drawings. And I remember being so afraid of that, and my mother kept saying, it's okay, we're getting the vaccinations, because we were lucky enough that we were able to get the vaccinations. Now growing up, I had a friend of mine whose mother had polio as a kid, and so she had, what, she wore a brace her whole life. And those were the things that like we kind of took for granted because those vaccines were out when we were kids. I feel as nurse practitioners, whatever our personal opinions are, we need to check them at the door. That if we have to do what's right for the patients. That if I had a personal opinion that I didn't believe in vaccinations, then I have an ethical obligation and a moral obligation to give my patient the best information for them to make an educated decision. Now, that being said, there's times when patients will say, "Well, what would you do?" And I always say, this is not my body. This is not my decision. I can only guide you as to what the data shows. And again, like you said, with vaccines, we can't. But I think it's across the board. We have to give our patients the best information out there. And whatever your personal opinion is, that needs to be kept aside. I just don't think that it's like our political and religious beliefs. There comes a point when it doesn't belong in the exam room, and whatever your beliefs are about vaccinations, it's the same thing. It doesn't belong in the exam room. You give your patient the appropriate data that's out there, that's most current, and what's going to be of benefit to them. So,
Absolutely.
yeah.
And I'll turn the tables on you to say this. When somebody says, what would you do? Then that's my open invitation to say, I'll tell you what I would do. I get that a lot, kind of palliative patients of saying, should we continue treatment? Should we not? We've done all of these things, they're not working. If somebody asks the question, then I'll sometimes, it depends, I don't always do that, but sometimes that's my inroad in to say, this is what I do. Now, how I always end it is just what you said. That's me. So you have to do what you think is best. So, you know, I'll just say that.
So, and it's interesting because, the patients come in and there's a list of vaccines that they're due for. And I'll say to the patient, people don't die from shingles. So let's say they need
Yeah.
an update on their pneumonia vaccine and their Tdap and, a myriad of other things. Maybe they didn't get their RSV. And I'll always say, if I had to prioritize something, people don't die from shingles. People die from pneumonia. People
All
die
the
from
time.
COVID.
Yep.
And you have X, Y, and Z in terms of your health conditions. And those would be the things that I'd be concerned with because that puts you in a higher risk category. Those are the people that those particular patients tend not to fare well if they get sick and they're not vaccinated. We know that our data shows that. And usually that's enough because instead of it's so overwhelming, I think, for patients when they come in, they're due for 5 vaccines, which I would never give on the same day anyway. But to break it down and say, flu season's coming up. That would be my priority. We're seeing a spike in COVID. Of course, there's no COVID vaccines, but I'll say, pneumonia. This is pneumonia season, and we're already seeing pneumonia. As of 2 weeks ago, it's August, and we're already seeing people with pneumonia. I think I saw probably at least 5 or 6 people in the last 2 weeks with pneumonia in August. So I tell patients, you can die. You're a diabetic, you already have asthma, you're a smoker, and so once you give them the right information that's based on facts, based on what their health history is, then let's say, okay, all right, I'll get my pneumonia vaccine today. So I don't coerce them, but I just try to give them the facts for what it is.
Absolutely.
So I don't have anything else unless there's anything else you want to bring up. I do want to take a look at some of the information if there's any questions here in the Q&A. Okay, so one of the questions is, what about calling in a non-opioid for yourself? And as our pain management specialist, I'm gonna leave that to you.
Well, now they did say a non-opioid.
Non-opioid.
So, here's the thing. You pick up the phone, you call in a prescription for Brett Snodgrass, prescribed by Brett Snodgrass. I think, like you said, I think there's a high likelihood you're going to get a call from the pharmacist saying, I don't know about that. I would never do that. I think again, I think it goes right along the lines with everything else. I think you're probably going to get that kicked back way before anything else. Just because you're calling in a prescription for yourself, I do not recommend it, no matter what it is. That's just not good. It's not good practice.
Exactly. All right, are there any other questions? We're winding down on our time here. We hope that you found this beneficial. If there's any other questions, please put them in the Q&A so we can address them.
As we finish up, one thing we really didn't talk about, let's just take really quickly talk about this. We talked about end of life, we talked about kind of decision makers and things like that. But what about caring for an elderly patient with a terminal illness? The patient has said, I don't want to be resuscitated. And I've had this happen. I don't want to be resuscitated. And the family says, okay, that's fine. But when they go unconscious, then I'm making the decisions.
So
And
I
we have
see that a
had
lot
that
in
happen.
primary care, Brett.
Huh?
I see that a lot in primary care
Yeah.
and every time the patient comes in for their physicals, we always have the question about, do you have a living will? Or the living will I have here is from 8 years ago. Have you updated it? And I always use the example, if it's not in writing, as you had said earlier, then it's anybody's guess what's going to happen. And I always appeal to the patient to say, you and I might have had that conversation to say, if I'm terminal, I don't want anything done. But your daughter's sitting in there saying, well, she's going to get intubated. I don't care. And so I always say to the patient, if it's in writing, then I can act as your advocate. Because if we've had this conversation, you have it in writing that you don't want anything done, then the hospice staff, the hospital staff, regardless of where you are, if you have it in writing, they can't really override that. Correct me if I'm wrong, if a family member can override what has been considered a legal and binding document.
What I'll tell you is they can override it. In fact, they can.
Interesting.
Yeah.
Well, I learned
In many
something new
states, they
tonight.
can override it. Now, it's always my conversation to say, let's talk about it because we know that's what they've wanted. Why are you feeling this way? Kind of, can we get to the bottom of it and really follow their wishes? We know it's their wishes. Interestingly enough, organ donation, if you have that little heart on your license, that is
Mhm.
legally binding. So, by golly, if something happens to you, whether your family wants to or not, you're donating your organs. And I'm not here to talk against organ donation because I work in an organ transplant program, but it can really feel uncomfortable at times. Sometimes that's a whole nother conversation. But if that's on your license, that is legally binding. Even if you have signed a post form, a post form, a most form, whatever you call it in your state, um, families actually can still override that. Here's the debate. The debate is the person that signed that and desired that is not going to sue you because they for not following it, but the family that's alive and well are the ones that potentially could take suit against you. I'm not telling you not to follow what a post form says, but that has been my experience of saying I have watched providers reverse it in some situations because family is adamant about it. No, and I would say that is a problem. Would you have a leg to stand on? Sure, you would. You'd have the signed form and whatever, but what we see sometimes is it's not followed because that family can be louder than that patient in those situations. So it's kind
Interesting.
of interesting. And again, I try very hard to very quickly get to the bottom of why are you feeling this when that was their wishes. We want to follow their wishes. 9 times out of 10 no, I won't say that often. Let's say 50-50. You can get them to change their mind. Usually what you're dealing with is family members that feel guilty or they have something that is causing them to make those decisions and go against their loved one's wishes. But believe it or not, many places they will still follow what the family says.
That's interesting. I've not had that experience, but I'm glad to hear that it can happen. And again, we can only be our patients' advocates, but and then appeal to the family and just find out what's driving your decision here.
Yeah, and the flip is that's why you want a POA of healthcare who will make your decisions. Because if you have a POA of healthcare and they make those decisions, it's done. So that's why it's so important to have in writing who you want to make your decision. It might not be your spouse. It might not be it's somebody who's going to follow the wishes that you have. And sometimes you hear families and spouses say, "Oh, I could never do that. I could never just let you go. I could never. And so sometimes it's not your spouse. It needs to be whoever's going to make your decisions the way you want them. And that's why you have it and you have conversations about what your wishes are.
Great, great point, Brett. Thank you.
Yes.
Okay, so we are just about out of time. This was great, Brett. I always learn something from you.
Well, you
So
too.
thank you. Thank you so much to everybody who took the time to be with us tonight. Thank you to my co-host, Brett, for all of your incredibly insightful and important information. And if there's any other questions that you come up with, please send them to Calibri and they will direct them to us. But until the next time, thank you so much for being with us. Take care now.